afternoon from Jakarta, from Indonesia. I would like to welcome all participants, also the speakers for today's Indo-Anesthesia's webinar. We will discuss about regional anesthesia in specific population, which is obese patients. And for today's event, I would like to thank Sona Medica Jaya and Wisonic for sponsoring today's webinar. This afternoon, we will have discussions led by two prominent speakers in the field of regional anesthesia. I would like to welcome Professor Paul Kessler from Germany and also Dr. Pryambodho from Indonesia. For today's webinar, the discussion will be led by Dr. Susilo Chandra. I think I will invite Dr. Susilo if you want to start.
Okay, thanks, Krisha. Greetings, everyone. Today, we will discuss about regional anesthesia for obese patients. As we all know, that obesity is an issue for us as an anesthesiologist. Airway management is one of the challenges in obese patients. Hence, regional anesthesia serves many benefits for the specific population. However, it's not always easy to conduct regional anesthesia for obese patients. This afternoon, we have two prominent speakers in the field of regional anesthesia. One is Prof. Paul Kessler from Germany. Thanks, Prof. And also the second will be Dr. Pryambodho, is my colleague, a good friend of mine. And Prof. Kessler will give a presentation first, then Dr. Pri will do live demonstration on the model. If you have any question, please do not hesitate to put the question in Q&A box. If you want to ask in Bahasa Indonesia, then we will help to translate them for you. Lastly, I would like to thank Wisonic International and PT Sona Medica Jaya for their support. Without further ado, please, Prof. Kessler, you may start your presentation.
So, I hope one can see my presentation. Good afternoon to Jakarta and a warm welcome here from Frankfurt. My name is Paul Kessler. I'm working in the University Hospital in Frankfurt in Germany. First of all, I would like to thank the Wisonic company for organizing this webinar. And I would also like Susilo Chandra for chairing this session and would like also thank the whole team from Jakarta for organizing this live demonstration. Thank you very much. This is my disclosure. I got honoraria from different companies and also in the advisory board from different companies, but this will not influence my presentation of today. So these are the issues I'm going to talk about today. What is obesity, obesity and anesthesia? What are the problems? Obesity and regional anesthesia. What is here? What we have to think about this? And what is the role of ultrasound in obesity? And finally, I will summarize my presentation. First of all, it's important to know what is obesity. We are talking about overweight if we have a BMI between 25 and 30. And from obesity, we are talking about of a BMI greater than 30. And we have different degrees of obesity. And we are talking of morbidly obesity if we have a BMI more than 55. And indeed, obesity is a worldwide problem. You see here the proportion of population worldwide with a BMI higher than 30. You see in the first row is the United States. You see these are not all the countries of the world, but you can see in Germany we have 22% obese patients, and in Indonesia, fortunately, there are only 7% with a BMI higher than 30. But the bad news is that obesity is on the rise in Asia and it's faster growing compared to the Western country. But as you can see here, in Indonesia, the rate is at 7% and it's in the middle field when you compare Indonesia with the other southeastern countries. You see also when you look at the overweight population, that mean a BMI higher than 25, lower than 30, they are 21. And again, Indonesia is in the middle field compared to the other Southeast Asia countries. The reasons why obesity is growing so fast in Southeast Asia, I think is the increased income, is the urbanization, and primarily is the fast food. Mainly among the obesity is fastest growing among children. Here you can see overweight children in the age from 5 to 17. And again, the good news here again is you see the arrow here. Indonesia is at the bottom of this list, of this graphic, and the rate is indeed very low compared to many, many other countries. When we are, as an anesthesiologist, we know when we do anesthetize in obese patients, there is a higher rate of complications. One of the many complications you can see here, compared to non-obese, the rate of myocardial infarction, wound infection, peripheral nerve injury, or urinary tract infection is significantly higher in obese patients. And this, and another problem in obese patients is the area management. And this is the potential benefit of regional anesthesia in these patients, because we can bypass the difficult airway. We don't have to manipulate in the respiratory tract. We don't need to give a huge amount, or we can abandon opioids and the opioid side effects. And as a result of this, patients can stay shorter in this PECU and can earlier left sent home. And from this knowledge, many societies, like here, the Society of Anesthetists of Great Britain and Ireland, published recommendations regarding obese surgical patients. And one of the recommendation is, wherever possible, regional anesthesia is to prefer to general anesthesia. But also, if we do regional anesthesia in obese patients, we also have problems, because we have a huge amount of fatty tissue, and this also increases or decreases the success rate in regional anesthesia in this population. And the challenges for regional anesthesia in obese patients are that the landmarks to recognize can be very difficult, landmarks such as bony structures or the vessels. And it's also difficult or nearly impossible, depending on the degree of obesity, to identify the nerves. And in any case, the distance from skin to nerve is increased in obese patients. So we also know that we have usually a higher failure rate when we do regional anesthesia. And there are some other recommendations we should follow in obese patients. When we do regional anesthesia, we should reduce the amount of sedation to a minimum. We should add local anesthetics to the lean body weight and not to the actual body weight. And if we have a spontaneous breathing patient, that means if we do a regional anesthesia for the procedure, we should keep the patient in the sitting positions. I come to this issue later. What are the data telling us about obese patients and regional anesthesia? You can see here a study regarding the axillary plexus block, including more than 600 patients, and the BMI was higher than 30. You can see here, with an increased BMI, the failure rate increases. We have also a lower success rate, more complications, and lower satisfactions. These are data from nerve stimulation guided blocks. We have larger databases here, 3 studies, including 9,000, 2,000, and again, more than 9,000 blocks. All of them were performed with nerve stimulation, and the BMI was likely higher than 30. And in all of these studies, it could be demonstrated that the failure rate was higher than 10% if the BMI was higher than 30, or the success rate decreased from 97 to 94 with a higher BMI, and again, a failure rate about 40% with a high BMI. We also know that obesity is correlated with other complications. Here, data from Germany network, including more than 13,000 peripheral nerve catheters. And with increasing BMI, the risk of catheter-related infection increases. So we have, on the one side, we have the clinical benefit of regional anesthesia compared to general anesthesia. On the other side, we have the technical challenges when we do regional anesthesia in obese patients. We need longer needles. Usually, for more than 90% of all our blocks in normal adults, we need only a 5 centimeter needle. But in obese patients, we need sometimes 10 or sometimes 15 centimeter needles. Here, an example of a transgluteal sciatic block with catheter. And this is a 15 centimeter needles removed after the catheter is placed. And again, another example here, sorry, I go back. This is an, sorry, this is an, I have to go back. This is an lumbar plexus block. You see a patient in a lateral position with a tattoo at the side, and also a catheter technique. The catheter is placed and the 15 centimeter needle is removed. So what about obesity and ultrasound? What do we have data from this, or what are the problems? The major problem is the penetration depth and the image quality. And you know, penetration depth and image quality are inversely proportional related. The deeper the target, the less poorer is the image quality. I will give you an example. This is an ultrasound image for a tap block in a normal adult with a BMI of 25. You can see very nicely the 3 muscle layers, external oblique, internal oblique tap, 2 centimeters. And if you do this also in an obese patient with a BMI of 45, you can see the image sharpness is not compared to the other ones here. The quality is rather milky, and you can see the target is here marked with the red arrows, is much more deeper, around 5 centimeters. And we have other issues why the image quality is poorer in obese patients, because of the fatty tissue. And if we have fatty tissue, this will increase the reflections as a fat muscle boundary due to the different velocity of sound between fat and muscle tissues. And in addition, we have an impedance jump at the fat fascia boundary with strong reflections. Both of these issues increase the brightness of the picture of the muscles, and this increase the hyperechoic structures, and this makes it more difficult to differentiate the hyperechoic nerve from the surrounding tissues. Here an example. On the left side, a patient with a normal BMI. This is a subgluteal area. You see the greater trochanter as landmark, and you see a very hypoechoic muscle structures. On the left, on the right side, you see a BMI with a patient with BMI of 45. You see the brightness of the muscles here, and on the left side, you can very nicely identify the sciatic nerve. But on the right side, you see the large fat layer, and here it's very difficult to identify the sciatic nerve. Another problem we are faced when we do regional anesthesia in the age population. And in the age population, also the sonoanatomy of the muscles is different, because we have a degeneration of muscle fibers, and we have, this is very important, reduced fluid and an increased connective tissue. All this together, again, makes the muscle more brighter, more hyperechoic. And again, this makes it more difficult to differentiate, to identify the hyperechoic nerves within the muscles. Here, an example of this. On the left side, you see the anterior thigh of a 28-year-old patient. You see the rectus femoris muscle, the intermedius muscle, very nicely hypoechogene. And on the right side, nearly 69-year-old patient, you can see the higher brightness, the hyperechoic structures of the presentation of the rectus femoris and intermedius muscle. Another example here, a lateral proximal thigh for a lateral proximal sciatic nerve block, the femur. Here, this is the muscles, and here the sciatic nerve is very nicely to identify. And on the right side, the picture of a 76-year-old patient, and you can see the sciatic nerve is demonstrated, is marked here, but the differentiation between the other muscle structures seems to be very difficult. So there is an unhappy zono-anatomical combination that is an old obese patient. Here, the patient in the lateral position for a lumbar plexus block, the Shamrock approach. And this is the picture, what you can see. This is anterior, this is posterior, and there is nearly no structure really detectable. And it's different to say, where should I place my needle? You have lost the external and internal landmarks. And in these patients, you can use ultrasound only as an assistance, not as a guidance. And you need, for detect the nerve, another technique or method to determine where the nerve is. And this is the nerve stimulation. And I come to this topic later on. Important is also when we have an obese patient and the distance from the skin to the nerve is longer, then we have a steeper angel. You see here on the left side an axillary block with a nearly parallel in a needle, and you can see very nicely the shaft of the needle. When you have a steeper angel here on the right side for an infraclavicular block, the visualization of the needle shaft is poorer. What is also a problem, sometimes we have to change the probe. Usually, as I mentioned before, for nearly all blocks, we can use in normal adults the linear transducer with a penetration that's up to 6 centimeters and a very good image quality. But in obese patients, sometimes we have to change the probe from linear to curved probe. The good thing is that we can see deeper into the tissue, up to 20 centimeters, but at the expense of the image quality. So this is not necessary for all blocks. Even in obese patients, we have some blocks where we can use, even independently from the obesity, we can use the linear probe. For example, these are the interscalene block, the femoral nerve block, or the adductor canal block. Here's some examples. This is a femoral nerve block in a patient with a BMI higher than 40. And you can see here is used the linear probe. Another example, BMI nearly 45. On the right side, you see the sono-anatomical image. You see the fatty layer. You see the femoral nerve in a distance between 3 to 4 centimeters. Here you see the local anesthetics. This was an out-of-plane approach. That's the reason why you can't see the needle. And also the interscalene block. For the interscalene block, to my experience, you can always use the linear probe. This is a BMI nearly 50 of a woman. And here the comparison of the interscalene, the sono-anatomical picture of an interscalene block in a patient with a BMI 26 on the left side and nearly 50 on the right side. And there is no so big difference in the test. You can, in both patients, very nicely see the nerve roots for the interscalene block. And the difference in depth is 2.7 on the left and 4 centimeters on the right side. Another example here in an obese patient. And here on the right side, you can see this is a superior trunk, but very nicely demonstrable with the linear probe. By the way, this is my wife is also an anesthesiologist, but she is only working in ambulatory setting, and she is doing a lot of shoulder surgeries. She is doing all the shoulder surgeries without ultrasound guided block because he had no ultrasound machine. She is doing a landmark guided suprascapular nerve block, and I will demonstrate this to you here. When the patient is in the sitting position, and another important thing is she is doing all the patients in general anesthesia, and she is in all patients placing a laryngeal mask independently from the BMI. You can see here BMI 51. And then when the patient is sitting, she is doing the block. She is looking for the angle of the spina of scapulae and the clavicle, and 2 centimeters medially, she advanced the needle until she has bony, when she has bony contact, then she injects 10 ml of local anesthetics. And this is a block which takes 1 minute. So back to our topic, to ultrasound and obesity. Here an example of the adductor canal block on the left side in a normal adult. You see the sartorius muscle, the fatty layer on the right side in an obese patient. You see here the different depth of the saphenous nerve. We expect the saphenous nerve just here lateral from the femoral artery, but also in nearly all obese patients, you can use the linear probe for the adductor canal. The same applies also for here's an example of a deep adductor canal block. Here you see here the fatty tissue and this is not the femoral artery, and here lateral we expect the saphenous nerve. But also for the distal sciatic block in the popliteal area, we can use also in the obese patients the linear probe. Here the corresponding muscles, and you see the fatty layers, and you see the popliteal artery as a landmark, and above you find the tibial nerve, and you can do your plot, and you can use the linear probe, but this is just the limit for the linear probe, 6 centimeters in depth. But we also have some blocks where we use in normal adults the curved probe. This is for the proximal sciatic or the psoas or the lumbar erector spinal plane block. Here an example, the lumbar erector spinal plane block in a patient with a BMI higher than 40. You have here the landmarks, the bony landmarks. These are the transversus process. You advance the needle here until you have bony contact with one of the tip, then you inject. Here the lumbar plexus block, you have seen it before, patient in the lateral position. You place the probe in the flank, and then you advance the needle perpendicular, and you can see here BMI 43. Again, what you have seen before, no bony, no landmarks you can see. And if I do a shamrock lumbar plexus with the shamrock techniques, I have only the lateral border of the vertebral body here. This is my most important landmark, because I know that just lateral from this bony landmark, there we expect a lumbar plexus block. And sometimes I only see the proximal shaft of the needle. This is possible because you advance the needle perpendicular to the probe. And if I see the proximal shaft of the needle, I know when I advance my needle where the direction of the needle, where the needle is guiding to. And when the direction is guiding to this area here, then I advance the needle slowly, but correctly. This is an ultrasound assisted nerve stimulation guided nerve block. And that means, I will go back, and that means for this block, I always need nerve stimulation together with ultrasound. Another example, this is the lumbar plexus block, the trident approach, the parasagittal approach. You see the transversus process, you advance the needle here. This is an out-of-band approach. You see the nerve stimulation is turned on, and you see the muscle movement, and we expect the lumbar plexus just around here. This is an example for a tap block. You see here again the increased fatty tissue and the 3 muscle layers, and we expect the target plane here around in a depth of around 6 centimeters. So no probe change is also, or probe change is sometimes necessary for blocks where we use usually the linear probe, and then we have to change to the transverse probe. Here an example for the adductor canal block. The depth of the target is nearly 8 centimeters. What I would always recommend if I do blocking of these patients and I have a poor visualization, I would always use before I the color function to check where are the vessels. So what tell us the data about ultrasound in obese patients when we do regional block? What about the success rate? Here, a publication of a TAP block in obese patients, and Here we have conflicting data. Some studies show no difference in success. Other studies show a difference in success. And this depends on the correct identification of the right plane, of the needle positioning, and of the spreading of the local anesthetics. This is another example, success rate of an ultrasound-guided interscalene block. Two groups, group is a BMI 22 and another BMI 35. And they found with an increased BMI, an extended time for block performance, increased pain score, that means a less success rate, and an increased opioid consumption, again, an indicator for a less success in obese patients. But there are also conflicting data. Another study of interscalene blocks showed no difference in success rate in obese patients. Here you see the two BMIs, and also a study comparing catheter placement for the popliteal femoral interscalene area, and there was also no difference in success rate in obese compared to normal patients. What about ultrasound versus nerve stimulation in obese patients? And here we have one study for the popliteal sciatic nerve. The BMI in both groups were similar, and they found with ultrasound reduced procedural times. We are faster and reduced procedural related pain and less pain during the procedure, but there was no difference in the success rate if I do a popliteal sciatic nerve block with ultrasound guidance or with nerve stimulation. But indeed, we have probably a higher complication rate when we use ultrasound because we have a poor visualization. And this is a case report of local anesthetic intoxication due to the poor visualization. In normal adults, when we use ultrasound, when we inject local anesthetic, we should always see the spread of the local anesthetics. If we inject local anesthetics and we don't see the spread of local anesthetic, this is always suspicious for an intravascular injection. And this visualization is impaired in obese patients. So in obese patients, we cannot say correctly, yes, can I see the spread of local anesthetic or not? And that's the reason why the risk for intoxication is increased in obese patients when we do an ultrasound guidance block. So what can we do when we do an ultrasound guidance blocks? How can we improve the technique in obese patients? What options do we have? First of all, when we do an ultrasound guided regional anesthesia for the procedure, we should always keep the patient in the sitting positions, not only, as you can see here, when we do a brachial plexus block here. This is the best way to do this is in the sitting position. But when we do the regional block for the procedure and we don't need any general anesthesia, we should always keep the patients in the sitting position. Here an example of a patient of our institute. This was a patient with a female patient with a BMI higher than 60. She had a hand operation, hand surgery. And this is a very old picture because I think it's 20 years or older, because at that time we did ultrasound was not available. And what we used in this patient, it was an ultrasound, a pen ultrasound, because it was difficult to identify the axillary artery. But with the Doppler, we could identify the artery, and then we used the nerve stimulation for identifying the nerves. When you do ultrasound guided block in obese, you should always pull away the fatty tissue. You can do it here with tape, as you can see here. And when you retract the tape, you have a nice area to place your probe. This is for an interscalene block, and also for a tap block, you can do an abdominal shift. You can turn the table on the contralateral side, and you can use tapes to remove the tissue. You don't need always to use tape, as in this picture, what we have seen before. If you have an additional assistance, you can also remove, in this case, the female breast with an additional person. Very important is that you know how to use your ultrasound machine and how you can optimize your ultrasound picture in obese patients. You should use the right frequency, the right gain compensation. You should use color Doppler before your puncture and compound imaging. And nearly all of the newer machines do have a software which enables you to enhance the visualization. In this case, you can see here green marked. This is an enhanced visualization program, and you can see the same needle on the left side with the normal picture is poor compared to the right side where you use the enhanced visualization program. How can you improve the visibility of the needle? You have several options again. Here, part in out of plane. When you use out of plane, you can use the tissue movement or hyperlocation. Part means you have to align, you tilt, rotate. You should use pressure or you can use rock. Very important and very helpful in obese patients is the pressure technique. I will demonstrate this in this block. This is an adductor canal block in a patient with a BMI nearly 50. On the left picture, you can see what the tissue without pressure, and on the right side with pressure. I mark it now with color. You can see here without pressure, the fatty tissue has 4 centimeters in depth, and then the sartorius muscle 2 meters in depth. So you find the saphenous nerve in a depth of 6 centimeters. This results in a very deep puncture angel. On the other hand, when you use pressure, you can see you can decrease the fatty layer up to 2 centimeters, and also you can decrease the depth of the sartorius muscle. In total, you will gain 2 centimeters in depth, and that means that the puncture angel is flatter and you have a better visualization of the needle. Another thing is you can use the heel-in maneuver. That means you keep your needle and then you place, this is for the adductor canal block, you place your probe and your needle, and then heel-in means you rock your probe in that way that you use pressure for the medial end of the probe. And when you do this, then the puncture angel becomes flatter and the visualization of the needle succeeds. And for out-of-plane technique, I have my personal technique. I will explain you what I mean. This is a typical way how we do an out-of-plane block. You advance the needle in this way, and then you can see only the tip of the needle when the tip of the needle is in the ultrasound beam. And here you can see when the bevel is up, you can see you should see 2 marks, the proximal end and the distal end of the bevel. But it's difficult. In this picture, it's easy because you have a hypoechoic muscle. But in the obese and old patients, when you have a hyperechoic muscle, to identify these 2 white spots, it's sometimes very challenging. I do a technique in these patients, and so-called in-out-of-plane technique. What does it mean? It means that I advance the needle from the white edge just close to the probe, and nearly I advance the needle in a vertical direction. That means that larger parts of the needle can come into the ultrasound beam, and this looks in this way. This is a lumbar plexus block. You can see here in this marked area, you can see the needle is coming here, it's advanced, and you see here parts of the shaft if you look very precisely. I hope you can see it on your screen at home. But this is called in-out-of-plane technique. It's sometimes very helpful when you have a deep block, and it's different to the original classical out-of-plane technique. Needle beam angel, I always mention on this. If you have a flat angel, you see very nicely the needle. In a steep angel, it's very poor. And if you do blocks in obese patients, you should always need echogenic needles. You see here the same block with a standard needle and the same block with an echogenic needle. You see very nicely the shaft of the needle, and the producers of these needles are also have marked on the needle tip so that you exactly know where the tip of the needle is. And here's a study demonstrating that when you use an echogenic needle in with higher puncture angles here, 50 degrees, you even have a high chance to visualize the tip, and this is not the case when you use a standard needle. And finally, if you are able to use one of the needle tip technologies, here this is one of the new technologies, this is the vision technologies. Here is the needle tip marked with a green circle, and the green circle when it represents the tip of the needle. And even if you don't see the shaft of the needle or the needle tip, and you see the green circle of the needle, you know exactly where the needle is. And this is very helpful for deeper block, especially when you do an out-of-plane technique. So finally, what does it help you when you see the needle or you have a poor visualization of the needle? You have improved your visualization and you have improved your image, but you can't see the nerve. So you need what you have seen before in obese old patients, you need an additional nerve detecting technology, and this is a nerve stimulator. Here, a publication where approximate sciatic nerve block was performed, and in 40% ultrasounds was necessary additionally to ultrasound to identify the nerve. And another study also for sciatic nerves, comparison normal versus obese patients, and only with the additional method of nerve stimulation, it was possible to see the nerve and to increase the success rate in these blocks. Again, here the lumbar plexus block, you see here BMI more than 52. Of course, you need here the long needle. The depth of the target is around 15 centimeters. You can't see no typical landmarks. The only what you can see is, for me, the most important landmark for this block, the lateral border of the vertebral body. Here you see nothing. This is hypoechoic. And I see the needle shaft, the proximal part of the needle shaft here. Then I advance the needle and I use the surrogate anatomical landmark. If I don't see the nerve, I use the lateral border, and I know that the lumbar plexus is located here. And only with the addition of nerve stimulation, I would perform this kind of block. Here for the subgluteal sciatic nerve block, again, BMI nearly 50, it's impossible to identify the nerve with ultrasound only, so you need the nerve stimulation. You use the greater trochanter as a surrogate anatomical marker. So finally, in the last part of my presentation, I will focus on the neuroaxial block. What can ultrasound do in obese patients with neuroaxial block? Again, what relies for the peripheral nerve block also relies for the neuroaxial blocks. You need longer needles. This is our standard needle. You need 11 or 15 centimeter needle in morbidly obese patients. Systemic review pointed out that we use ultrasound for neuroaxial as a pre-scan. And when we use it as a pre-scan, we can define the interspinal space. We can measure the depth from the skin to the epidural space. We can increase the success rate, and probably we also can increase safety. Here, when we use ultrasound, we use usually in adults the curved probe, and we place it in a transverse view. And when you have a transverse view, you can identify this is a normal adult. You can identify the interspinous ligament. You can identify the articular processes, the laminar, the transverse process, the interstitial space, and also here, this is the anterior complex. The anterior complex, this is the posterior part of the vertebral body. Here, comparison of palpation, landmark palpation and ultrasound, and you can see to identify the interspinal space, and in 32% with palpation only, the interspace was too difficult, and this can be sometimes dangerous because if you are too high, probably you can hit the spinal cord when you advance your needle. This is a comparison, ultrasound versus landmark in obstetric. I think obstetric, these are the main population where we do lumbar plexus blocks, lumbar neuraxial blocks, and you can see 6 trials including nearly 650 patients, and with ultrasound the number of puncture attempts was lower. We had fewer puncture levels, success rate was higher with the first attempt, and we had a lower rate of complications. We do it, as I mentioned before, as a procedural technique. We place the probe in the transverse and in the sagittal view, and we mark the interspinous space, and we mark the midline, and the intersection of both is where we do the puncture. But in very obese patients, we have sometimes a poor image resolution. It's difficult to visualize the bony landmarks, the spinous process, and to identify the midline. This is again, this is a comparison ultrasound versus landmark in obese patients. And you see with ultrasound, these are the red bars. The first attempt was we had a higher success rate with first attempts when we use ultrasound in obese or difficult patients. Another study here comparing landmark and ultrasound. You see here when you use landmark, the palpation of the spinous process was difficult when the BMI was higher compared to low BMI, and also to identify the iliac crest was difficult only when you use palpation and landmark techniques. With ultrasound, we had a higher success rate, but in this study, it was found that the BMI was below 30 or higher than 30. There was no difference in the success rate. So even in a higher BMI, ultrasound was very helpful. But this is not related to all decrease of BMI. In higher decrease of BMI, ultrasound, the visualization becomes more and more difficult. Here, a patient with a BMI of nearly 40. Here you still see the bony landmarks, the posterior complex, which means the dura and the ligamentum flavum, and the anterior complex, which represent the posterior part of the vertebral body. But if you have patients with a higher BMI, here 46, you see you have still poor landmarks. There's only visible the anterior complex, the posterior part of the vertebral body. Other landmarks disappear. And if you have morbidly obese patient, as you can see here in I don't know exactly the patient, I think the BMI was 55. It's very difficult to identify with ultrasound any kind of landmarks. Here an example, BMI 51. There are no more bony landmarks. Bony landmarks are lost. What you can only see are the bilateral paraspinal muscles, and you can identify maybe the midline, but you don't see in which depth you can expect the epidural space. So in morbidly obese patients, you can use as a pre-scan, but ultrasound has limitations even as pre-scan because you have very different conditions, poor visualization, limited orientations, and this is not something for beginners. So, and this is my final slide. The topic was obese patients, a challenge for ultrasound guided blocks. I hope you could see that expertise is necessary. It is not something for beginners. You should always get expertise and you get skills in normal patients. It takes more time to perform an ultrasound guided block in obese patients, but difficult blocks are not this does not rely to all blocks. Some blocks, as you have seen, the femoral nerve block or the interscalene block, are not more difficult in obese patients. We have physical limits of ultrasound if we have a target depth of 10 centimeters or deeper in depth. Really challenging are obese and old patients because the visualization or the changing of the structure and the ultrasound of the muscles makes it more difficult to identify the nerves. You should use an adequate equipment, a high resolution ultrasound machine. You should know how to optimize your ultrasound picture. And in very obese patients, you have seen, we use ultrasound no more as ultrasound guidance. We use it as ultrasound assistance. And to identify for the identification of the nerve, we need an additional method, and this is usually the nerve stimulation. And you should always accept that your regional anesthesia doesn't work. And for that case, you should always have a plan B if you have a patient with a not well working block and you have to secure the airway. Thank you very much. And this finally shows you life is challenging. And this here are the Swiss mountaineers, 5 Swiss mountaineers on the thin top of a mountain in Switzerland. Thank you very much.
Thank you very much, Prof. Kessler, for nice presentation. And you know, although Indonesia is still less than 10% that has obese patient, but I think the future is now. We don't want to wait. We have to know how to cope this problem in very near future. So I think it is the very good time for us to learn about obese patient. Yeah, you have so many cases in Germany, of course, but we also have like 1 or 2 cases per week. I think like in obstetric cases, I think we found that more than 30 BMI. Before we start with Dr. Pri, then I have a question from the audience, from Dr. Sahrul. Is it possible for the ultrasound guided trident lumbar plexus block in obese patient identify corresponding spinal artery during or before procedure? Any preferred out of plane needle orientation relative to transfer plexus age to avoid arterial puncture? Do you have any question of this?
This is a good question, but to my experience, I think it's very difficult to identify spinal arteries if you use the trident technique. I think the visualization of the surrounding vessels when you do a lumbar plexus block becomes better when you do a shamrock approach. And always when I do a shamrock lumbar plexus block with a shamrock technique, and this is not to rely to the shamrock, nearly to all blocks in deep patients. Before I do the block, I use my color function to check if there are vessels around the nerve. And indeed, the lumbar plexus area is a vessel-rich area, and you should always use the color function. But in very obese patients, it's very difficult to identify, even with color function, the vessels. And I think it's more difficult with the trident technique compared to the shamrock technique. But in both techniques, it's difficult, very difficult. Sometimes you succeed to identify the vessels, sometimes it doesn't work.
Yeah, I'm happy that your last slide is mentioned that there is a still possibility of fail to do that. So it is very good things for us to know. So maybe we can start Dr. Pri first to do the live demo with Professor Kessler. Hopefully it is very interesting. We have 2 cases. One is a normal case, but the other is BMI 40 maybe. Okay, Dr. Pri, please.
So I think we start with the patient in the sitting position. In my last part of my presentation, I showed you some new AXA blocks in obese patients, and when the patient is sitting just here, so I think we can start also with a new AXA block. Please, Dr. Pri, show us when you do it. This is, I think, this is first the normal, the patient with the relative normal BMI. Yes, is it correct?
Yeah. Okay, the first page. Am I still mute or unmute? Okay.
Already, Dok.
Okay, I'm in. Good afternoon, everybody. Good day. Assalamualaikum. Here we have two cases. This person is a normal person with a BMI 20, and the other one with BMI 42. So we'll see the difference between these two patients. First, we are trying to scan the neuraxial ultrasound. So this is how I do it. First, I tried put my probe. I'm using the low frequency, and I put it not in the midline, but little bit to the left or the right at the paramedian line. So when I put the probe like this, this wrist, so we can see that's this one. This is very flat white line. This is the sacrum, and the first groove. This is a cranial, and the right, your right is caudal, left is cranial. So the first group after the sacrum is the interspace between L5 and S1, and this is L5. This is interspace between L4 and L5. We can see the depth to the image is about 3.5 to 4 centimeters. It is in the normal patient. Now we'll see how it is in the obese. So this is median, so the paramedian is right here. I have to push quite hard to find the structure, because if I'm not doing the pushing, we can see the structure is very deep. It's out of the image now, so I increase the depth. It's maybe at, sorry, where is it? It's about 10 centimeters depth from the skin, perpendicularly, the sacrum. So when I want to make a more clear image, I have to push quite hard. Now I can see the sacrum is getting more shallower. What with quite push. This is at 8 centimeters, and the first groove is L5S1 interspace still there, and this is L5 and L4. And we can see the structure is not very different, but only the depth from the skin to the vertebral structure that's very different between these two cases. So that is right what have been mentioned by Professor Kessler, that yes, ultrasound can help us easier how to identify where the space is to the spinal or the epidural. But after that, we also need the longer needle than the usual we use with our patient. So this is the first cases, and I to continue the transfers. This is the horizontal view. So this is the L sacrum L5S1 here, horizontal view. So we can see the image. Need to increase the depth. Okay. I have to tilting a little bit. I cannot get the. Now I can get it. Okay, but it's anterior, so the posterior complex. I try to find the anterior complex. It's very hard to find. This space is L1, S1, L5, S1. I try to move upward.
Here,
And
no,
I get it. This may be at the level L4, L5. We can see Where's the cursor? Oh, sorry. Where's the cursor? Okay. You can see the structure that has been explained by Prof. Kessler. This is the image of the ligamentum intraspinosus. This is the anterior complex, and this is the lamina. Transverse process. And the canal spinal should be here. And if we try to measure distance, okay. The anterior complex is at 8 centimeters. So if I put about here, 1 centimeter above, it should be there where the canal spinal is. So the depth is 7 centimeters. So the regular needle, it's maybe not enough, which is usually at 8 centimeters, and you have to push very hard to get the cerebrospinal fluid coming outside from the needle. And
can I make a comment on this? Can I make a comment on this? Sorry, can we go back to the picture here? I can. Could you remove the line you marked, the marked line? I think we can, even in these obese patients, you can see above the 2 small white lines, just above no, just in the middle. Yes, exactly. This here, this is the intercecal space, and probably the line above this between this is the epidural space. The small, exactly. This is the epidural space. I would suggest.
Yeah. Yes, agree with that.
Very nice. Even in this obese patients, you can identify the epidural space. Great.
Okay, so we move to the next case in normal one. This is L5, okay. L4, 5 Get it? Freeze. Yeah, we got almost the same picture, but with different depth. Only the anterior complex is only less than 5 centimeters in the normal with the BMI 20. And this is the posterior complex. Same here, maybe there is 2 lines. There are 2 lines. Maybe this is the dura, this is the ligamentum flavum.
Exactly.
So if I want to measure, it's only about 3.8 centimeters from skin. Okay, that's what I can show you for the for the neuroaxial blocks. Any further question or any comment, Prof. Paul?
Good request. Could you please demonstrate on the normal adult the parasagittal approach, and can you so that we can see the intracecal space?
Okay.
I think it would be possible because.
Miring ke kanan. Okay. Ya, miring sana. Parasagittal obliques. Okay. This is what we get. Sorry, where is the? Okay. So your left is the cranial, your right is the caudal. So this is the L5S1, L4, L3, and L. This is when we are scanning at the paramedian. So when I'm sliding a little bit to the midline, we can see the structure is like this. This is the lamina. Can you freeze it a moment? Freeze.
Can we decrease the depth a little bit?
Yep. This is the lamina. This is when I'm facing perpendicularly from the skin. Unfreeze. Okay.
Could we again you decrease that? I think the depth is too.
Oh, the depth, yes.
Depth is too. Can we decrease a little bit the depth so that it can be better demonstrated? Okay. Yes.
Oh, you get it? Okay. This is the lamina. If I'm moving right in the midline, I cannot have a good picture because of
fantastic here. Yes.
So I move back to the lamina, and I'm tilting my probe towards medial, so I get this. Okay, this picture like this. Yep, freeze. This is the lamina. This is the sacrum. This is L5, L4, and this line could be ligament of flavum, and this is the posterior dura, and this is the anterior dura or the anterior complex, and this is also the posterior dura. It's actually, it's not interrupted like this, but because it's hiding behind the lamina, it cannot be seen from our image. So, any comment from this? Jangan di, okay. Come back again. Okay. Oh, no, not yet. Not freeze. Come back again. Okay. Yep, freeze now. Okay.
Very good. Yes, very good.
Okay. This is the posterior dura. So we have to puncture this to get the liquor. If we want to do the epidural, just stop above it.
Exactly. Very good.
We try to our.
You can try, yes.
Yes, tolong baring miring, ya. Jadi, baring, ya, good. Jadi. Okay. Then your left is a cranial, your right caudal. Okay, that's sacrum. Okay. Sacrum L5, L4, L3. Okay, we can decrease the depth. Okay. So I try to find again the lamina. So I got the lamina now, but not as clear as
You
the.
can see it's more difficult in these obese patients, yes. You don't see the leading structures not so nicely.
Yes. I cannot see the dura, maybe only the lamina and
maybe here you can see the intrathecal space only here, about here.
Sorry, tolong baring yang enak, miring dikit. Ya, ini agak maju. Oke, good. I try to reposition the patient and now I scan again. The sake. Okay.
Stop.
Yep.
Here, stop. But I think here you can see, so this may be here. This is the intrathecal space, yes?
Maybe here.
It's difficult. It's really difficult. And this is what we have seen. This is our daily practice in these obese patients.
Okay. And still I have to push quite hard to get this image.
Yes, I believe.
Yeah, now I get it. So this
yes.
Is
here now, yes.
Okay, but the of course it's more deeper and the angle you want to do in plane is very steep. It's steeper.
Yes.
Okay. Anything else then you need to show?
I think when the patient is in the lateral position, we can demonstrate the erector spinal plane block.
Erector spinal plane block.
Yes, block, yes.
Unfreeze.
Or the trident approach, the lumbar, it's up to you.
Oh, okay. No, until now, is there any request from the audience? Not yet? Okay. I will show at the thoracal area. So this is the mid. Okay, midline is there. So I can see the lamina. So I'm a little bit on the right lateral. So I move again to more lateral. And I get this picture.
Very nice picture, yes.
This
Very
is,
nice picture. Yes.
I produce it. Okay, this is the coste. I have to move a little bit medial. Yep, freeze. Okay, see the, sometimes we are not so, what is it? To do, you have to differ between the transfer process and the coste. If we are
Yes.
doing the block at the coste level, it means we are too lateral. More of the time the block is not working, but we have to put the needle just at the lateral tip of the transverse process.
Exactly.
This one. So
Yeah.
the superficial part of this transfer process is more flat than compared to the coste. This is more
Exactly.
round.
Yes, exactly.
So the depth is about 4.5 centimeters.
Mm.
Yeah, it's not quite deep, but the structure I think is almost similar to the normal one. Maybe the depth is less instead of. So I try with the normal one, the BMI 20. Oh, jangan dihilangin tadi. We lost the picture. I'm sorry you lost the obvious picture. Now this is okay. Now I'm at the level of the transfer process where I'm moving more lateral and I get the coste. Transverse process again. And this is the lamina very flat. Back to here. Please. So this is the plane.
Yes.
Put the injection
Yes.
for the ESP block.
You see much more superficial compared to the other model.
Yes, less than 3 centimeters.
Exactly. Can you move to the thoracic area and to demonstrate an ESP?
Thoracic.
Thoracic ESP.
ESP. This is at the thoracic area. I scanned it at the thoracic area. This is at maybe T5. Yes, T5, at about T5. This is not at the lumbar.
Yes. Now we move to the thoracic area for the ESP.
Oh, this is the thoracic area. What
Yes.
I've done, not the lumbar. Yep, this is at the thoracic area. So when I'm moving down caudally, I need more jelly.
Maybe we can use the linear probe in the normal patient.
Okay, we can do that. To compare.
So we have better visualization, a better image quality.
Exam. Linear. Okay. Okay. Musculoskeletal. Okay.
This is a block we are doing very often in our department.
Okay. This is the ASP.
Yes.
Transfer process. When I move lateral, I see the pleura, and this is more round. This is the coste. I move back to.
Yes. Very good. Yes. Yes. Exactly. Very nice image. And the superlying muscle structures, the ESP, exactly.
Yep. This is target here. Okay. What else? Should we see the shamrock?
In the lateral position, yes, of course, we can do it, yes.
Okay.
What do you think? I think we have to change the probe again to the curved probe.
Mhm. Okay. Iliac crest, so I put it just cranial to iliac crest. I need to, oh no, yes, I got it. I don't have to increase. So I got a thumb sign and it's a Shamrock sign. And we freeze.
Left is anterior, right is posterior, yes?
So right, left is anterior. Oh, okay. Please. Okay, let's start. Okay, this is the vertebral body.
Yes,
Transfer process. It is
yes,
the quadratus lumborum, psoas muscle, and
yes,
this is the paraspinal muscle. This is the Shamrock sign.
exactly.
So if anybody wants to do the lumbar plexus, maybe around here, Prof. Kessler, the target
Exactly.
with using.
Maybe you can use the color function when you use the camera to demonstrate. Maybe we can see some vessels.
Okay. Now we're adding the color. Color, please. Make it small. Okay, we have put the color, but
you can see it's difficult sometimes. It's difficult, but you can see they are around where we expect the plexus here. Maybe there are some vessels.
okay. Not appearing in the image, but yeah,
Mhm.
anatomical say that it is,
Yes.
but we cannot
Yeah,
see it.
yeah. Very good. And this is also the view how we do the anterior quadratus lumborum block. Yes.
Yeah. So
Can you please show with the arrow where we do the anterior quadratus lumborum block?
yes, wait a minute. So let's freeze. So anterior quadratus lumborum, this is the QL. It just pointed by the thumb from the thumb side. So this is the QL muscles. Look like trapezium, and
Yes, yes, exactly.
this is the internal muscle of the abdominal wall.
Yes.
So at this intersection, I think this point, this is my target for doing the anterior part. Anterior block is here between the QL and the psoas muscle, but I don't see.
Yes, exactly.
I'm not happy with this picture to do the anterior. Okay, for me it's better. No, please.
Yes, yes, yes.
I can see this is the psoas
Exactly.
muscle, and this is the fascia between the psoas and the QL. So
yes, good,
where
exactly. Yes, here we do the, and what you have shown before with the arrow, this was the lateral approach, the lateral QL.
Yes, it's lateral QL.
And the posterior, we would do, you can also demonstrate with the arrow.
Yeah, I have to tilt
Yes,
in.
exactly,
So I
exactly.
can see the line, the fascia is not very clear, but this is the space.
But yes, yes,
But here.
exactly.
Okay.
Very good.
Okay, we try to make good picture and then we keep it and compare it with the obese one. Let's freeze. Yes. Okay, we try to scan with our friends with the 42 BMI. Let's see what we can find. Miring seperti ini juga. Okay, maaf. Where's the iliac crest? It's
So
hard.
I like, in my institution, we like the psoas, the lumbar plexus block. We like it very much.
Okay, this is what I, where's the, not so clear. Okay,
Left is anterior and right is posterior.
that's the same. So I don't want to make a disorientation. So still left is
I
anterior.
would say here on the left side, you can see this is the left, this is more to the left. We see on the left side, we see the lateral border of the vertebral body. If you show more, a little bit more, show us more from the left side of the picture.
Wait, this.
Yes, this one. I would say this here is the lateral border of the vertebral body here. And this here is the hypoechoic muscle. This is the quadratus lumborum. And below the psoas muscle, yes. And here below you see the lateral border.
Yeah, but I'm not sure where the lateral border is. Where is it? This line or this line?
No, more on the left side, more on the left side.
Here?
No, more on the left side.
On the
No, I would say no.
No,
Here.
no.
Yes, yes, here. This is the lateral border, yes.
Here.
Here. No, not here. More lateral, more on the left side.
Here.
Yes, here. This is for me, I think this is the lateral border.
So I have, yes, this.
Yeah. This is the lateral border. This above is the psoas muscle, and above is the quadratus lumborum. It looks a little bit,
yep.
Have the triangle form.
Where is the cursor? So this is the lateral border. This is quadratus lumborum.
Yes, this is quadratus lumborum, exactly.
Let me see. Let's try again. See, it's very difficult to identify.
Yes. Yes, but this is daily practice. This is our daily practice.
Sometimes when I in doubt to identify the QL muscle, I go back to the abdominal wall and try to scan the layer and try to follow it until I got when it meets the QL muscle. So I have this is the transverse abdominal wall muscles is internal. This is external. Becoming.
This is a transverse. Yes, this is the QL muscle, quadratus lumborum, where below, this is the QL muscle, below is the psoas muscle, and below the psoas, the hyperechoic structure below the QL is the psoas, and then below, this is the shadow of the of the vertebral body.
Yes, so I put it like that.
And in front of the vertebral body, you see the pulsation of the aorta and the inferior cava vein below here.
Yes, so this should be the lateral part of the vertebral body. This is transfer process. This is the QL muscle right here.
Yes.
And the aorta should be located over here, but it's a freeze, it's an image.
Yes, but this, indeed, in the obese patients, you have lost nearly all the landmarks, and it's very difficult to identify, and to use the nerve stimulation as an additional technique to identify the nerve is mandatory.
Yes. Oh, quite difficult. Okay. Oh, here is the vessels there.
Yes, yes.
No, don't freeze it. Just put color, maybe we can, if you like it. Color. Okay.
This color down here, yes, exactly here. Here are the big vessels, yes.
Yep, that's right. Okay. Okay, then.
Okay.
Okay.
Now can we move to the supine position, I think?
Okay.
Or we can you demonstrate? Yes, okay.
Which block now?
We start on top with the interscalene.
Interscalene.
I would suggest.
Okay. We change the prop to linear. Now the brachial plexus. Okay. Okay, now, okay. Your left should be medial or the anterior, and right is the posterior. So I got this. This is the anterior scalene muscle.
Yes,
Scalene root is here.
exactly.
Now you can see the brachial plexus. This is the maybe L5, L6,
Yes,
and the structure is quite the same. It's not so deep, but 1 centimeters compared with the normal.
exactly. Yes. This is what we expect in normal adults. Absolutely. Very superficial, just below the skin.
Okay. Now maybe I can continue to the supraclavicular area.
Yes.
The artery is coming. Yep, this is artery. Artery, and this is the brachial plexus. Superficial and lateral to the artery, and this is pleura, and this is the first rib.
Yes, exactly.
Okay, same superficial, and I think it's not differ to the normal BMI. But for the, should we continue to infraclavicular?
Yes.
We need to increase more depth.
The lateral sagittal approach, yes.
Lateral sagittal. Lateral sagittal is, okay, sorry. It's like that.
Or the coracoid approach. It's called different names, yes.
I can identify the artery, but the other structure is not clear. But most of the, yes, Prof?
Even if we don't see the nervous structures, we know that they have to be around the axillary artery. And if we inject a local anesthetic around the axillary artery, we know that we have a well-working block.
Yeah, I agree with you, Prof. But most of the time, I found that if we put some needle with nerve stimulator,
yes,
this is the structure, the brachial plexus.
Exactly. Yes.
Okay.
Very nice.
It's not very deep, 3 centimeters. I think it might be a different only 1 to 2 less than 1 centimeters with the normal. Okay, and what else?
Is this our the PEX block, PEX 1, PEX 2, and serratus?
This is mid axillary. This is okay. This is a major PEX. This is the minor PEX. PEX 1 is should be between here. Okay. This is PEX 1 space here.
Yes. Between both muscle layers, yes.
Yeah. For PEX 2, you can put here below the what is it? The minor PEX.
This is the serratus here, yes. Between serratus anterior and PEC minor.
Yeah, this is just anterior muscles.
Yeah.
And I'm moving more caudal and lateral, and I need the jelly. Tangannya bisa ke samping atas gini. Nah, okay. Okay. Make major, minor, serratus anterior. Where is the? Okay. Discoste, the pleura, same, still the same. And this number 2, 3, and this still number.
Right side is posterior, yes.
Yes.
Right side is posterior, so we would expect the latissimus dorsi muscle when you go more posterior.
Ya, ini ke atas tangannya gini. Nah, santai aja. Ya, oke. Pectoral serratus anterior. Oh, sorry. But again, I have to push quite hard because if I'm pushing quite hard here, because if I'm
Yes.
not pushing, the fat layer is about 2 centimeters more.
Yes, 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 yes. Yes,
Okay.
go
Yeah.
ahead, go
So
ahead,
here,
go ahead, go ahead.
as that is anterior, and I think
Maybe here's the latissimus dorsi muscle coming.
yeah,
Yes.
this anterior, serratus anterior is latissimus dorsi. Should be here.
It's not so a thick one in this patient, the latissimus dorsi. It's not so very thick.
Yes. Because I'm pushing so hard, I'm a little bit difficult to slide laterally.
Yes, yes, yes.
Stuck at the skin.
But this is the same. This is the typical problems we have in daily practice with these kind of patients. This is always the same. And that's why it's a realistic scenario, what you are showing us here.
Yep. Okay, this is what the best that we can get. This is at serratus anterior. Should be latissimus dorsi is above it, just above it, but very, very small one happening here. Oh, yeah, because there's so many fat there.
Mhm.
They're not
Yes.
at the right line. Oh. Oh, I think we are,
Yeah, yes.
but very, very small latissimus dorsi here.
That's right, that's right. Okay, now you can move to the maybe to the tap block.
Tap block. Oh.
This is a block I think you also use usually in your daily practice.
Okay, left is anterior. Di atas. Iliac crest is here. It's about. Okay, here. Okay. When I don't push it, this is the fat.
Yes.
And it is about more than 4 centimeters.
Yes, yes, yes.
To push quite hard, and I got.
Maybe you have to increase the depth.
That's it.
Yes, or you have to do a probe change because maybe with
Ganti dengan ini.
and this is typically for some obese patients or for some blocks that you have to change from the linear probe to the curved probe because the target is too deep for the linear probe.
Now I can get it. This is the 3 layer of abdominal muscle, external obliques, internal obliques, and this is transverse. So for tap block, it should be about here, but I'm scanning not in the mid-axillary line, so I have to sliding more lateral. Okay. Wow. Okay. This is the best I can get still.
Can you decrease the brightness a little bit so that we can, it's too bright, a little bit darker?
Yes. Yeah.
Yes. Okay, thank you, thank you.
So this is lateral side at the mid-axillary line. I still got the internal oblique, external oblique, and this is transverse. So this should be between these two muscles.
Yes, this was the tip of the arrow. Yes, this is the plane where we have to place between the internal oblique and the transverse abdominis.
Ooh. And is there any? You can see how hard I should push this.
Yes.
Oh. Okay.
Wow.
Yes, yes, it's wow. Yes, yes.
It needs more energy for doing this.
You need a lot of energy and pressure. Yes, yes, yes.
Okay.
Exactly. Okay. So now we can move more downwards. What about the femoral nerve block?
Okay. We can change to the linear first. Mau di pangkal paha ya. Femoral. Ini. Nah, okay. Okay, sorry, lipat paha. Ini now. And again, I have to push, so I got the yang ini tolong lepas saja. Yeah, okay. This is femoral artery. Welcome one. This is the vein, and I have. Okay, this is the picture. Okay, I got it.
Yes.
Artery, vein, and this is the femoral nerve. This is the fascia iliaca.
Yes, yes, yes. You see, even in the obese patients, usually the femoral nerve block is an easy nerve block, not so different to normal adults. You don't have to change the probe. You can use the linear probe, and if you use a little bit pressure, you can do it also practically in the same way as you do it in normal adults. Can you show the adductor canal block?
Adductor canal. Okay, di paha. Scan paha. Ini aja di atasin. Oke. Yang yang abu-abunya di atasin. Oke, yang ini di bawah. Ya, I'm sorry. Boleh dicopot aja. Okay, wow. Oh my God. What a size. Jelly. No, that should be here. Please. Okay, let's see. This is arteries, but need more depth. Oh, quite difficult. We have to change the probe. I think I got the sartorius muscle, but I cannot see structure.
I think this is the sartorius muscle here. Yes.
Yes. Sorry, I have the sartorius.
This is the sartorius muscle, and below we should see.
Oh. Oh no. Let me track.
I would follow the artery from the inguinal groove downwards.
I did. This is the artery. Follow it. Now,
yes.
Sartorius.
Sartorius. And now when she is in the midline below the sartorius, yes, a little bit more.
This is sartorius. And
yes.
Okay. More depth.
When she, yes. And now we have to increase the depth, and yes. A little bit more distal, so that she is in the middle below the sartorius muscle. This is a typical way to do a little bit more, I would say, a little bit more caudally.
If you it's quite difficult for me to scan now because it's very thick. This is the best I can do. I think we have to change the probe.
Yes, but but this is on the right way to do the block. Yes.
Dikit aja, dikit. Up. But yeah, okay.
Now we can decrease the depth a little bit.
Yeah.
Yes, this is good.
Yeah.
Now a little bit more deeper. So yes, a little bit more. Yeah. So now she is around a little bit less brightness, please. It's too bright. Yes, great. Yes. Now this is, I think, the correct position, and you can see lateral. There we expect the saphenous nerve, and now the femoral artery is around in the middle below the sartorius muscle, and this is a position where we would perform the saphenous, the adductor canal block. Yes.
We have to use the Prof since the linear is not enough.
Yes.
Okay. Anything else?
What about the distal sciatic block in the popliteal crease?
Okay. So let's miring lagi. Miring. Ini lihat aja. Saya mau pakai ini ya.
In the meantime, I see in the chat there are many questions. I try to answer the questions. There is one question: why in neuraxial anesthesia do you recommend ultrasound guide pre-puncture instead of during puncture? I think the real-time ultrasound guided neuraxial block is extremely difficult. Usually you need a second person. You can do it one-handed, but it's extremely difficult, and nobody recommended to do a neuraxial block as a real-time ultrasound guided block, but all the recommendations are going in that direction, that you should use the ultrasound as a pre-scan. Then you mark your injection point, and then you place the probe away, and then you do your puncture conventionally. The next question is, for the obese patient, are the volume of block increase or still normal volume? I have shown you that you have to adapt the dose of your local anesthetics, not to the actual weight, but to the ideal weight. That means, for example, for men, the actual weight minus 100, and for women, actual weight minus 105. And then this is the local anesthetic dose. Now we continue with the demonstration. Yes.
I'm at the pancreatic crease. I got this. Oh, no, just non-unfreeze. Okay, can you see it? This is the
Pulsation of the artery, the popliteal artery and the vein. Yes.
popliteal and vein. So I have to, should be here the tibial nerve. But
Yes.
Sliding more proximal. Your left is the lateral, right? Is
Yes.
quite difficult. I lost the structure. I got the tibial nerve, but not yet the.
I think if you go more proximally, they are separated. If you go more distally, they are becoming one nerve.
Yes.
More proximally, you can see probably the peroneal nerve and the tibial nerve as two separate nerves. And then if you move, you see one nerve, and if you go distally, you can see the separation into the two nerves, the tibial and the peroneal nerve. Yes.
Yes, Paul, but you see,
I would say here, this is
please, can you see this? There is a big sulcus there, and then it's quite difficult to sliding the.
yes.
I try to slide down. So still, okay, this is the tibial nerve. I try to follow it.
I think the peroneal nerve is more lateral on the lateral side. Lateral, yeah. Left is lateral, yes?
Yes, but this is the tibial nerve. But I'm quite difficult to track it proximally, technically. It's getting blurred and nothing can be seen. I try to retract the skin. That skin, still we cannot get the good image. So this is the best that I can get, the tibial nerve. So I now try to tracking to caudal. Maybe I'm lucky. Okay, not visible. No.
But I think you have seen the peroneal nerve just on the left side. Left is lateral, yes? Is this correct?
So maybe this. But I'm
Maybe
not
this,
sure.
yes. This
But I'm not
structure,
sure.
maybe.
No, I lost it. So it's quite hard in
Yes,
this patient to scanning through all the surface of the skin because
yes,
so many sulcus, so many.
yes, yes, yes. But again, this is a typical situation in our daily practice.
Yep.
I think here, yes, here's the, now you see on the left side, you'll see the peroneal nerve.
Should be here.
With the, yes, yes, this one is the peroneal nerve with the big hypoechoic dot in the middle.
Yeah.
Here, this, yes, this one. This is a big dot in the high. This is the peroneal nerve, and more on the right side, this is the tibial nerve.
Yes. This is to be enough.
Exactly.
Okay. I think that's the best image I can provide to you.
Yes, 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 yes. Mm, yes.
Okay.
Okay. I think now we have demonstrated. Are there requests from the audience to demonstrate something? Otherwise, I would continue to try to answer some questions.
Okay.
If you don't mind, Susilo, yes?
Yes, please.
Okay.
Because there is one question in Bahasa Indonesia. I will translate for you from Daniel. He asks, when we conduct the quadratus lumborum block in obese patient, shamrock or thumb sign are often unclear. Any tips when we are doing like this?
So the question was when we're doing a quadratus lumborum block, yes?
Yes, sometimes shamrock sign and thumb sign are not clear visualized.
Usually for me, I always prefer, even in obese patients, when I do a quadratus lumborum block, the shamrock sign. To get the shamrock sign, because with a shamrock sign, usually in obese patients, you can clearly show the quadratus lumborum block. And when you see the quadratus lumborum block and psoas muscle, you can easily perform the anterior quadratus lumborum block. And as Dr. Breyer has demonstrated, the lateral quadratus lumborum block and also the posterior quadratus lumborum block. But a prerequisite for do this block is to clearly identify the quadratus lumborum. And this, to my experience, succeeds very well when we do the shamrock approach.
Okay, thank you. There is still some question.
So Dr. Susilo.
Yes, please.
If we cannot see the structures, going to plan B.
Okay. What kind of plan B?
Yeah, maybe convert to GA or anything.
Okay. Or do with
just like what is written in the profile slide that we have to backup plan.
Right. Is that right, Paul?
Yes, absolutely.
Okay. But we can do it now because we don't have anesthesia machine.
Yes.
Okay.
There's another question. I can read the question. For neuroaxial anesthesia in obese or severe obese patients, what is the preferred method for produced based on evidence? Is it ultrasound guided or landmark? I think it's difficult to answer because the recommendations are not so clear. But I said before, I usually always use ultrasound for neuroaxial blocks as a pre-scan. And in obese patients or even in patients with scoliosis, I'd always use ultrasound before I do my landmark guided block. With ultrasound, I check where is the interspinal space and I check where's the midline. I mark this, then I put my probe away, and then I advance my needle conventionally. And even if I have a scoliosis, I turn my probe in that way that the spinous process is perpendicular to my probe, and then I look for the angle different from the midline, and then I advance my needle in this angle towards the epidural space. So I check always with ultrasound the situation, the anatomical situation, then I put my probe away and I do my real puncture, I do landmark guided.
Okay, thank you. Because I remember a long time ago, Professor Carvalho from Canada also demonstrate to us, in case you have the machine, do it every time with ultrasound to have a good result, like you don't puncture the bone, something like that. If you do it better with ultrasound, then do it.
Maybe that is right, but this technique is only related to a very, very few people. Yeah. And this is not the general recommendation because it requires a lot of expertise and a lot of skills, and I would not say that this is a recommendation for every anesthesiologist, even if you are experienced with ultrasound. But this requires especially a special experience when you want to try a real-time ultrasound-guided new axle block.
For difficult cases, for obese, for scoliosis. Okay.
Yes.
Do you have any comment?
Yeah, yeah. It is ultrasound is very useful for us, especially if dealing with the difficult case, especially obesity. But unfortunately, obese is maybe we can say it's an unpreferred case for the ultrasound. It's not matched. It's maybe the enemy for ultrasound because we know that the limitability of the ultrasound waves, it cannot travel so far. So if we have tried with ultrasound and we cannot get the target, so yes, we have to do the anesthesia with any other techniques and not spending our time to try to scanning, and then maybe surgeon will get mad of us because of long time we spend.
Still, one question from Bali is for the pediatric cases, obese pediatric cases. What is your experience about this?
Yes, it's the same as an adult, so it's not so different from the adults. When you are usually performing regional blocks in kids, you can do it also in obese kids. It's the same situation as an adult. The distance from the skin to the nerve is a little bit longer, and but usually in smaller kids you can use for all the blocks the linear probe. So this is not a magic bullet. It's easy to perform when you are experienced in pediatric regional anesthesia.
Okay. And maybe we should have general anesthesia first, yeah, to make the patient easier for us to do the puncture.
Yes, when I think it's generally the general recommendation. The smaller the kids, the more we do it in general anesthesia first. We do the general anesthesia first, and then we do our regional block. Otherwise, the patient would harm because an uncertain movement of the patient when you advance a puncture can lead to a nerve damage or something else. So it's better. And it's safer for the patient when you do in small kids the regional block after general anesthesia, or you can do it in really deep sedation.
Okay, thank you. There is still a question from Dr. Sahrul. He asked about the position when you do a neuroaxial block. Do you do in lateral decubitus or in sitting? Which one is better? It's easier for anesthesiologists to do.
I cannot answer this question. I do it in the sitting and I do it in the lateral position. Sometimes I start to do it in the sitting position then the patient gets some drowsy, and then we have to place the patient in the lateral position, and then we do it, of course, in the lateral position. Kids, we do it after general anesthesia, we do it always in the lateral position after general anesthesia. But it depends on the patient. So for me, it's not a different. Usually one said when we do it in the sitting position, you can better stay in the midline. It's easier to stay in the midline compared to the patient in the lateral position. But it's up to you, what you prefer. So there is no general recommendation to do it in that way or in that way. Depends on your personal preference.
Yeah. Do you have the same answer, or do you have any other opinion about this?
You asking me, Dr. Susilo?
Yes. About the position when you are doing neuraxial block.
Yeah, it's a very self-opinion. So, and it's everybody's choice. Maybe someone will choose the sitting position, the other will maybe the lateral position. It's the matter of how to put the patient to the position which make us easier to access the epidural or the spinal space. But there are so many positions other than just lateral and sitting. Maybe you can see it also the pendant position. But no recommendation of what is better than the others.
Okay, good. So there is still question from Sony Sunarso. Is it possible to view the
what is DRG?
Dorsal root ganglion
DRG, dorsal root ganglion.
ultrasound? Is it possible to view with ultrasound? Not possible.
Not possible.
Not possible. Okay.
If you mean the DRG is the nerve, structure of the nerve, no, we cannot see because it's maybe lying just beneath the anterior, the articular process of the vertebra. So maybe it's not coming out from the vertebra, still under the vertebra. So it's quite difficult to make image of the structure. Yes. But if you want to do the procedure of DRG injection for pain management, yes, we can use ultrasound for guidance.
But can you see with ultrasound?
Oh, we cannot see.
No, we cannot see.
So the answer is we cannot see. The other question is from, do you still have any live demo, Dr. Pri? Or if not, we proceed with the Q&A.
Oh, I think we have enough with the demo.
Yeah. So the next question, how much the difference, if there is, from perspective of the volume and concentration of local anesthetic for the same type of nerve block between obese and non-obese one to achieve the same outcome?
I think usually there should be no difference between obese and non-obese. The difference would be if the nerve is lying surrounded from fatty tissue. When this would be the case, then we can assume that more local anesthetics is reabsorbed from the fatty tissue. But usually the fatty tissue is not around the nerves. The fatty tissue is in the abdominal wall, and the nerves are lying in obese patients in the same area where they are lying in non-obese patients. That means between muscles, between muscle layers, and so on. And there is no additional fat tissue. That's, for me, there is no difference in the volume or concentration if I do a block in an obese patient or non-obese patient. But we know for all the truncal blocks, we need higher volumes compared to the nerve blocks, and truncal blocks are not nerve blocks because we don't look for nerves.
Yeah.
But I have read 1-2 articles about the volume difference between the obese and the normal one for neuraxial anesthesia. Professor Paul, what do you think about that? They said that we can use a lesser volume for epidural.
Yes, we can do it. Yes, of course. There's no question against this. Yes, absolutely. I agree. Yes, yes. Yes. Today's last question is from Dr. Astrid Pratidina. But I think Professor Kessler already answered this question, is about how to give the dose, the volume. The volume is in for the obese compared with non-obese patient.
For me, there's only one nerve lying surrounded by fatty tissue, and this is the sciatic nerve in the popliteal area. In the popliteal area, the nerve, the tibial nerve and the peroneal nerve are surrounded from a lot of tissue. And that's the reason why we have to use more local anesthetics when we do these blocks. Maybe in very obese patients, the fatty tissue compound is increased and we have to increase the volume, but usually the nerves are not surrounded from fat. And that's why we don't have to change our volume in obese compared to the normals.
Oh, do you have any other things that you want to give to us, Professor Kessler and Dr. Pri? I found that Pri is have a big task today, because from up to bottom, everything already done.
Yes, yes, yes. I would say for me, this was the first time worldwide that I have seen a live demonstration in a normal adult and in an obese adult. It was fantastic, Dr. Preya. Yes, very, very fantastic. You did a very good job, absolutely.
Okay.
And I've never seen it before, and this was a fantastic live demonstration.
Give a big applause to Dr. Pryambodho.
Yeah.
Okay, I think we have already 1 hour 55 minutes. Very useful, very interesting topics to discuss. As I told you before, that this is the future is now. So we have to prepare if the patient is coming with obese, then we already know about how to do block for the patient. And I think I can wrap up that. Everything is already in Prof. Kessler slides. Now we come to the end, and I give the mic to Dr. Krisha.
Okay, thank you, Dr. Susilo, for moderating the discussion. I would like to thank Prof. Kessler. Thank you for spending some time with us this Sunday. And thank you, Dr. Pri, and for demonstrating all the blocks, even though it's not easy, but we can see it very clear. And also, I would like to thank Sona Medica Jaya and Wisonic International. Thank you, Mickey, for sponsoring this event. And last but not least, I would like to invite all the audience. Mas Ucup.
Slide.
Yeah. So I would like to announce that the International Symposium on Spine and Paravertebral Sonography 2021 will be held on 14 August until 4th of December. It will be done in alternate Saturdays. It will start at 5 p.m. Hong Kong time, so it's GMT plus 8. It's about 6 p.m. Jakarta time, or 12 p.m. in Germany. If you like to join, please do not hesitate to capture the link. And if you can register through the usgr.hk, that's the web for the registration. We will have all the faculty from all around the world, with the chairperson will be Prof. Manoj Karmakar from Hong Kong. So I think that concludes our session for today. Again, thank you, Paul. Thank you, Dr. Pri.
Thank you.
Stay
Yes.
safe, stay healthy, everyone, and hopefully next year we can gather around. Fingers crossed. Hopefully next year.
Yeah. Okay.
Bye
Bye.
Have a nice weekend, everyone.
Same to you. Nice weekend. Thank you. Bye bye.
Bye.